We're going to move on to surgical techniques in adult degenerative deformity. We have Claudia Lamartini with us. Please, could you share your slides, Claudia?
Yes.
Thank you.
Can you see my
Yes, we can. Yes.
Okay. This is my, first of all, thank you very much for involving me in this very, very interesting event. This is our team in Istituto Ortopedico Galeazzi in Milano, Italy. This is the new Galeazzi ready in 2 years. My topic today is surgical techniques in adult degenerative deformity surgery. This is few seconds for my disclosure information. I'd like to focus in my presentation 4 key points. The first is the Novo Scoliosis and adult idiopathic scoliosis. As we discussed before, we have to consider that the value or the huge value of this classification is because we can recognize the etiopathogenesis. The etiopathogenesis of different adult scoliosis is relevant for the treatment. I will try to focus this point. This is a typical case of de novo scoliosis. As you can see, when she was 55, there was no deformity. 2 years later, you can see a significant lack of lumbar lordosis because of the collapse of L3, L4. In the same time, you can see that the direction of the sacrum is different because she is developing compensatory mechanism. The first strong compensatory mechanism is the pelvic retroversion. 3 years later, you can see the evolution of this degenerative cascade. You can see very well a true scoliosis in coronal plane. In fact, you see at the apex of the curve a significant rotation. But what is really important is you see a complete loss of lumbar lordosis. You can see also a total verticalization of the sacrum. That means we have a huge pelvic retroversion. Obviously, in this case, you have to evaluate also the MRI, the symptom of the patient. At that stage, the symptom was a radicular pain and deficit. She was operated for this, but this was only, there was no chance to interrupt the degenerative changes without a surgery in L3, L4. This is the final step of this kind of de novo scoliosis. Here you can see very well kyphosis in lumbar area, pelvic retroversion, lordosis in thoracic area, and you can see also a flexion of the knee because of the extension of the hip. Totally different is idiopathic scoliosis in adult. In this case, we have a relatively early onset of the scoliosis, very often at 8, 10 years, but the shape of the deformity is totally different. You can see a severe progression of the deformity. This is a Lenki 6. You can see that there is a significant evolution in terms of cobangle, but also in terms of degenerative changes. You can see also a thoracolumbar kyphosis. But as we said before during the discussion, in this case, there is no significant pelvic retroversion. The compensatory mechanisms are less. Even if we have a severe malalignment, in sagittal plane because of the thoracolumbar kyphosis. But the thoracolumbar kyphosis is actually the result of the extreme rotation of the lumbar scoliosis. Two different animals. In every case, we don't have to forget what the goal of our surgery. We have to restore a good spinopelvic alignment. Jean-Charles Levesque explained us very well how we have to proceed. In this specific case, as you can see, we adopt what we call a delta construct. This is a very simple and cheap way in order to reinforce the posterior instrumentation, especially when you perform a PSO. Very often you have to add also a cage, a large cage, just in order to restore the anterior column stability. The second key point is posterior surgical techniques. I will show you how it's possible to achieve a good sagittal coronal alignment with posterior surgical technique in case of adult degenerative scoliosis. This is an example of the Novo Scoliosis. Here you can see is a typical shape of deformity of spine, because the curve is very short. There is a complete lack of lordosis, lumbar lordosis. We can see very well the all compensatory mechanism. This is the picture, pre-op picture of the patient before surgery. It is a typical example of de novo scoliosis according with the AB classification is type 1. We planned to perform a T10 pelvis fusion plus an L3 asymmetrical PSO. Usually we prefer to perform a PSO in L4 because the effect of this in the sagittal plane is significant more. If you want to simplify, if 20 degree of correction is enough in L5 in order to restore a good sagittal alignment, you have to perform more in L4. You have to like 25 degree and more in L3, like 30 degree if you want to achieve the same result. But in this case, we have to accept a compromise, because with our osteotomy, we have to try to treat both deformity in coronal and in sagittal plane. In this case, L3 asymmetrical PSO is a good compromise. In fact, the result is a good result, and this result is stable at 2-year follow-up. One more example. Once again, a case of de novo scoliosis. Here you can see how severe is the deformity, how it's really impossible for the patient to have an acceptable sagittal plane alignment without using the hand in order to help the general posture. In this case, once again, a case of de novo scoliosis. We plan to perform a T9 pelvis with L1, L2 ponte osteotomy, L4 PSO. This because we want to try to reduce the stiffness of the curve in coronal plane. It is the reason why we decided to perform ponte osteotomy at the apex. But in order to restore the sagittal alignment, we decided to perform an aggressive L4 PSO. As you can see, you have a very good result if you compare the ideal spinopelvic parameters with the post-op result. But mainly, you have to look at the picture before and after the surgery. They use a huge difference, even if it is only immediate post-op. Different is if you have to treat an idiopathic scoliosis in adult. As you can see in this example, this when she was 17, when she was 49. Here, once again, the same problem. You have a severe progression of deformities in coronal plane. And also in sagittal plane. But what is different? The difference is that in idiopathic deformity in adult, we see very often a kyphosis in thoracolumbar area. And this is because the main curve, the apical rotation of a main curve is relevant not only in coronal plane, but also in sagittal plane. That means this is once again the scoliosis that we see in part in sagittal plane. Many years ago, Pierre Stagnara defined this kyphosing scoliosis. This is the main difference with the deformity that we can see in sagittal plane in case of de novo scoliosis, as previous said Max. Here you have to obviously to describe the deformity and to define what's the goal of our surgery. Here you can see the picture of the patient. We plan to perform a T4L5 fusion plus an L2 asymmetrical PSO, just because once again in this case we try to achieve a good one osteotomy. This is the reason why we are so far from L4. But the point is, this is an idiopathic scoliosis, not de novo. That means there is no significant problem between L4 and S1. And the amount of lordosis between L4 and S1 is close to be normal, because it's a different problem. Here you can see the result, the clinical result. Finally, one more example. This is once again a case of de novo scoliosis. Here you can see very well. We decided to perform a L4 asymmetrical corner osteotomy plus a T10 ilium fusion. We discussed before, Richard focused at this point, how often we plan to perform 40 degrees of PSO. At the end, we achieve significant less. Richard focused also the need that we have to measure what we are achieving with our surgery during the operation. And in this way, we can reduce the amount of revision surgery. Here you can see that how we can close in very strong way the osteotomy, even if you have to treat the patient with poor bone quality. Here you can see very well in lateral the amount of correction is close to 65 degrees. This is actually not a real PSO, but is what we call a corner osteotomy. But once again, the key point is, if you perform this kind of surgery, you have to pay attention about the posterior implant. You have to pay attention in putting in compression of the posterior element. But the problem remain. When you perform so aggressive PSO, even if you achieve very good post-op alignment in both plane, you have a stable result, as you can see in this case. You have to consider that very often with the PSO as a significant risk of non-union. Non-union means that, like in this example, a 2-year follow-up, you have a non-union at the level of the PSO, a rod breakage, a PJK. That means the patient needs to be reoperated. Here you can see the result of a new operation. Once again, we create what we call a delta rod construct, just in order to reinforce the posterior implant. And also we try to restore a good stability of the anterior column, implanting a 30 degree of lordotic cage with a lateral approach. This is the result, the clinical result. But even if we pay attention about this, at 1 year follow-up, we had this rod breakage. We had to reoperate the patient, implanting 2 extra short rods just in order to reinforce significantly the stiffness of the implant. But the key point is that we have to realize that when we perform a PSO, we have a sort of floating vertebral body because there is no connection with the rest of anterior column. If you want to stabilize this, the only solution is to put cage above and below. There is no other chance. But this means one more surgery. This means extra cost and so on. This is the reason why we suggest the corner osteotomy, because in this case, when you put a cage below, you put in compression the level of the osteotomy. And this is a very efficient. Look at this. This is an inch-op fluoroscopy. Here you can see the amount of correction with the corner osteotomy in L4. It is the final global kyphosis, is close to 70. It is what is our target. At that point, the posterior instrumentation was completed. We turned the patient, we put a large cage just here, because in this way we had the chance to promote interbody fusion because of the large cage at that level. But in the same time, we were able to put in compression the area of osteotomy, closing the gap that we have after the first step of our surgery. And doing this, the risk of non-union is significantly less, especially if you put also in compression the posterior elements. In fact, you can see that we are achieving in this specific case a very strong posterior anterior fusion. Point number 3, anterior surgical technique. The point is we can consider this option without changing the goal of our surgery, obviously. And what the advantage of this? The advantage of this is that this is a less invasive surgery. We know very well that osteotomy creates significant, a significant risk for our patient in terms of mortality, complication, and risk of second or third surgery. With this kind of approach, without osteotomies, we try to achieve the same result with a less invasive surgery, like in this example. We can consider this when the supine fulcrum film is like this. We can see that there is a significant reduction of the deformity if you put supine your patient with a pillow below the apex of lordosis. In this case, we can plan this kind of surgery. We start with the ALIF in L5S1, then we turn the patient and we put cage with the transverse lateral approach in L4, L5, 3, 4, 1, 2, and 2, 3. Here, the result of this surgery, between L3 and L4, we put a hyperlordotic cage. In this way, as you can see, achieve a good spino-pelvic alignment without performing any osteotomy, reducing the risk for the patient. This is not obvious always possible. But the point is, if you have a relatively flexible deformity, you can consider this kind of surgery. Here you can see the final result. One more example. In this case is a case of de novo scoliosis. As you can see, the main problem is in sagittal plane. You can consider also in this case the option to perform anterior surgery with a lateral approach or with a poor anterior approach. In fact, in this case, we perform an ALIF in L5S1, an ALIF in L2 to L5, plus a posterior instrumentation. As you can see here, you see the ALIF, the 3 level of XLIF. The result is very close to be ideal in terms of sagittal coronal alignment. Here you can see the patient. The last example, in this case, as you can see, the severity of the stiffness of the scoliosis is a significant worse. Here you can see the patient also. We plan to perform a lateral approach, a posterior fusion, as you can see here. With the 2 levels of XLIF, we were able to restore a good lordosis. This is very close to exactly the ideal one. Also, the distribution is very good. What is relevant is also the correction of the scoliosis because of the extensive release with this kind of approach. This is the patient before and after the surgery. The last point is combined anterior and posterior. This is useful in extreme complex case in which, in every case, we want to achieve the goal that we have to define before surgery during our planning. Here you can see the huge deformity in both plane. We perform an ALIF plus a PSO, a symmetrical PSO at the apex of the deformity. And this is the final result in which we use this kind of kickstand extra rod, just in order to control also the coronal alignment. In conclusion, as we discussed before with Max Sebi, it's necessary to consider very well if the deformity, the scoliosis in our adult patient is de novo or adult, are two different animals. De novo very often need to include the pelvis, adult idiopathic scoliosis not. This is relevant for the patient. We can choose posterior, anterior, or combined techniques. The point is to maintain the same goal. We cannot change our goal because we change the surgery. But there is no discussion in case of anterior surgical techniques. We are less invasive than in posterior. But sometimes it is impossible to avoid the aggressive osteotomy, especially as you consider the case in which you have.
You are muted.
Thank you very much for your attention.
Thank you, Claudia. I think excellent talk. Any questions and comments, Mehmet?
There is one question from the participants about the blood loss. Is it an important issue or not?
It's very important, obviously. You have to consider that when you perform an osteotomy, the risk to bleeding is very high. You have to add this specific bleeding with the rest of the bleeding during your long surgery. This is the reason why we try to perform anterior surgery, because in this case the bleeding is significantly less. When we achieve enough correction, with the anterior surgery, very often we percutaneously complete our surgery with a posterior in instrumentation. The bleeding is very important in case of PSL.
I mean, I think the osteotomy itself is more bloody than anterior interbody fusion, anterior lumbar interbody fusion. Am I right?
Totally agree.
Yeah.
And you have to consider that usually lower you are, more bleeding you have. That means usually your bleeding is more if you perform an L4 or L5 PSO, and less if you are in L1, and less if you are in T2 or T3, for instance. But obviously in this case, the neurological risk is significant more.
Okay, brilliant. I think